and thank you for joining us for another segment of Ask the Therapist. Today we have a special guest, Dr. Raymond Scott, who is a psychologist in St. Louis, Missouri. Hello, Dr. Scott.
Hello.
Nice meeting you.
You too as well.
Would you give our audience a more thorough and formal introduction of yourself and tell them a little bit about your background?
Sure. I am a clinical psychologist, licensed in private practice here in St. Louis. I'm also a community psychologist as well. I'm currently in private practice. I have an office in the Central West End. I do a lot of work with individuals who are dealing with trauma, whether it's physical trauma, sexual trauma. I also do a lot of work with individuals who are experiencing forms of anxiety, depression. And I do work also with people that are struggling with different types of identities, whether it's a racial, sexual identity, and a lot of times that brings up spiritual issues as well. So, and then I also I have a lot of clients that are struggling, as I say, with depression or with anxiety, and a lot of individuals that have post-traumatic stress disorder as well. So.
Oh, okay. So Dr. Scott, as you can hear, covers several different areas of mental health issues, and he does have a local office here in St. Louis. Do you offer any services online, Dr. Scott?
No, I don't.
Okay. Okay. So, and of course, we will add more information about Dr. Scott's practice at the end of this segment. But I'd like to ask you, with informing our audience, sometimes there are issues that people have concerns about, and they may have certain symptoms and not really sure how to address certain symptoms. What are some of the main concerns or issues you deal with on a regular basis? I know you mentioned several, but do you have a particular clientele or a certain group of interests or issues that you work with most commonly?
Okay. So basically I work with individuals that are 13 or above.
Okay.
So I initially started with children, but because of different practices and decisions, I ended up working more with adults.
Okay.
So I focus on 13 and above. And as I said, I'll get a lot of clients that have major depression, anxiety disorders, and that's pretty common right now because of the economy and also because of the political situation in so many ways. Okay.
Yes.
Additionally, I get a lot of people, again, that have experienced some type of abuse. So I do an awful lot of work around trauma, and I've taken courses, and I have a tremendous amount of experience dealing with traumatic experiences with people.
Okay.
And so those tend to be the main ones. And again, I also deal with individuals that are going through concerns about their own gender identity and their own racial and sexual identities. So, and I also work with a community organization here in the city of St. Louis that's specifically focused on individuals that are struggling with HIV. They're living with HIV or AIDS. So I do a lot of work in terms of their mental health as well.
And which community services?
It's called the Community Wellness Project.
Okay. Okay. Wow, interesting. So give us like a typical, I guess you could choose either one. If there was a person, I guess, that was maybe struggling with sexual identity, gender identity, what would be the process that you would use? Would the person normally contact you, a family member, or what's usually the procedure? How does that happen?
Usually the person does contact me. In fact, I get most of my referrals because I'm on a website that's a local therapist, and it sort of gives a summary of the type of services that I provide, and it also talks a little bit about the populations that I work with as well.
Okay.
And so I get most of my referrals from that. I also get a lot of referrals from different insurance companies as well. And so, for the most part, because of that, I don't have to necessarily reach out. People are reaching out for the services.
So when a client contacts you, and you mentioned insurance also, is that usually the case that a person, if they were interested in having you analyze them or going in for the initial contact, would they need to have coverage with insurance first, or is that something you work around?
It can be either way.
Okay.
Most of my clients have insurance.
Okay.
Some of them are self-pay.
Okay.
Right. So that's one of the things we established at the initial request.
Okay,
Right.
great, great. So I guess if a person was interested in contacting you, you mentioned the websites and the several networks that you work with to get referrals, but just for the purposes of our audience who may be viewing this video, how would they then first seek the initial session? Would it be to contact their insurance company, to contact you directly? Either way?
Usually, they contact me directly. But a lot of times what they will do first is look at their insurance, because insurance will also list their providers.
Okay.
And so that's another way that they can also determine whether or not they feel I would be the appropriate therapist to work with them.
Okay.
Okay,
Right.
right. And then once they come, again, usually one of the second questions after they ask if I'm taking new patients is, do you accept insurance? And then they will tell me what insurance. And I accept most of the major insurances, so that's usually not a problem for individuals.
Okay, great. And you mentioned you're located in the Central West End. Of course, that's a central location that most people are familiar with in the St. Louis area. Now, you did mention something about anxiety and how there may have been an increase in patients who are seeking your services for anxiety issues with the economy and the political, I guess, situations we've been incurring lately. So is that mostly what the majority of your clients are now? Are they clients who are looking for services for anxiety? Or
interesting, most of the clients that come have both anxiety and depression.
Okay.
The two tend to go together. And so I would say they're not the majority of my cases, but I would say a third of them are anxiety and depression, maybe another third would be trauma, and then the other third would be kind of a mixture of identity issues, developmental issues, coming to terms with themselves.
Okay.
And I also do couples work, I'm sorry I didn't mention that as well.
Okay.
So in that other third, all of that's sort of a mixture.
Okay. So I've heard not lots, but often people mention they may need a therapist, but they don't want to appear to be crazy or have concerns that they can't handle. So we may be the last resort. They may try, using substance. They may try talking to their peers. They may try talking to their pastors. And then, maybe as a last resort, they come to us. But what would how could a layperson, determine when their issue or their concerns is, I guess, elevated to the level that they would need to seek out help from a therapist?
If you look at particularly the main diagnostic tool that we use, which is the Diagnostic and Statistical Manual of Mental Disorders, DSM, and the most current version is DSM-5. It defines any type of clinically significant disorder as affecting that person's ability to function.
Okay, so functioning.
Right.
Okay,
So
sure.
if you have impairments in functioning, that could be impairments in terms of your cognition, that can be impairment in terms of your emotional regulation. Again, it could be impairments in terms of, again, your interpersonal relationships with others. It could be impairments that prevent you from working on a regular basis, taking care of your children.
Okay.
Again, so you're seeing a significant impairment in one or more of those areas. When that's the case, that's the time to come in to be evaluated and then to seek help.
Sure. So if you are then incurring your symptoms and they're elevated to the level that they're impeding your everyday normal functioning, that would be something that would be of a concern enough to maybe seek out help from a therapist, because we're able to then assess you and see what levels of interventions you may need for whatever concerns you have. Now, you did mention, yes, and I can also agree that there has been an increase in clients who are experiencing symptoms with anxiety and depression, but also I have probably the majority, maybe, 70% of my clients are females, and they range from maybe the age of 20, maybe 21 to maybe 60, but the majority of them are right in that the majority of my clients are probably in that millennial age group, and some of them also maybe be considered quarter-life crisis group, and having several mood swings. I guess I want to get to the mood swings because often when females are experiencing mood swings, there could be several things going on, but they all seem to come to me and think someone has either told them or they've done some research somewhere and think that they have bipolar disorder. So I'm hearing that a lot, and it's a common term that's kind of thrown around, I guess, in the public or in the lay society. So would you just give us some information, or do you have you experienced a lot of clients often coming to you with the same concern about mood swings and thinking they may have bipolar disorder?
I do get several clients that come, and some come and say that's what I have and I need treatment for it. Others come and again they have the symptoms and they want to know what is going on for me. But one of the things I try and help clients to realize, particularly female clients, is, you know, I mean, your menses can cause a lot of elevation and, and changes in your hormones, which can cause changes in your mood swings. So we need to rule out some of those things first, you know. And I think the other thing, too, that most people don't understand about bipolar disorder is that it really is defined by the manic episode. And most people think of it as a rotation between mania and depression. And some bipolar individuals never experience depression. And so the defining symptom is having a manic episode.
Okay. So that's very important to know, and thanks for pointing that out. This is a topic that we probably need to discuss more thoroughly in detail because, like Dr. Scott just mentioned, clients often come to me as well saying, I have bipolar disorder, and they wanted to be treated for bipolar disorder when that may not be what the case is. One other thing I wanted to mention, though, when you talked about the clients coming to you with the symptoms and probably have pre-diagnosed themselves, sort of, are they often coming to you looking for medication treatment, or are they understanding the difference between what you can do with counseling versus the medication treatment? And do you often refer for that, or how does that work?
A lot of clients are confused between what it means to be a psychologist and a psychiatrist. So if they come specifically asking for medicine, I do explain to them the difference, that I am primarily a therapist that will provide counseling, psychotherapy. If they need medication, I will refer them. I do give them several referrals to different psychiatrists in the area. And I'm very specific. I want them to go to psychiatrists because so many people that are primary care physicians also prescribe medications. Unfortunately, they don't have the background to do that. And so that's why I want to stress to them, make sure you get in to see a psychiatrist that really has the expertise to prescribe the medicines appropriately. Okay. So I'd love to talk to you more about the medication and the difference between the psychiatrist and general practitioner, and why that's so important to distinguish the difference when you're being treated for mental health concerns. Okay, so we will try to go back to the bipolar disorder discussion because that is one that I know several of my clients, a larger population of my clients, have concerns about, and Dr. Scott has a lot of much more knowledge about bipolar disorder that he may be able to inform you all thoroughly about how to distinguish between regular mood swings, menses cycle mood swings, and bipolar disorder. So if you would come back again and we can discuss more about bipolar disorder and inform our audience a little bit more about that and some other concerns they may have. Thank you so much. Thank you.
I appreciate it. Okay. Yeah. Hello, and thank you for joining us for another segment of Ask the Therapist. Today, we have a guest, Dr. Raymond Scott, who's a psychologist who practices here locally in St. Louis, Missouri. Hello, Dr. Scott, and nice having you back again.
Thank you. I'm glad to be back.
Okay, and would you again just give our audience a little bit more information about your background and your practice?
Sure. Okay. So I received my degree in clinical psychology in 1996. I did my graduate work at Oklahoma at the University of Tulsa. Once I completed my graduate program, I also went into teaching, so I was in academia for about 15 years, which gave me a good foundation in terms of helping others to train to be psychologists, and it also allowed me to do a lot of research, because if you look at the current emphasis on evidence-based practices, it really gave me a foundation to appreciate what it means to have an evidence-based practice.
Sure.
Okay. All right. I was licensed in 2001, and so I've been practicing since that time. So practicing in private practice for now about 16 years.
Okay.
I originally practiced in California, and I just returned to St. Louis a year ago. So I've only been back for a year, and I've started the private practice, and I now have a waiting list, so things are going very well.
Okay, I was going to ask the difference between being in California and practicing here. Obviously, when you say you have a waiting list, things are going probably better here. Okay,
yeah.
You're originally from St. Louis?
Originally from St. Louis.
Okay,
right.
Okay, great. Okay, so Dr. Scott has been here before, and the last time he was here, we discussed several aspects of his practice and some of the issues or concerns that he usually addresses with some of his clients. And one of the concerns that we discussed was bipolar disorder, because that's one of the more popular concerns amongst at least my clients, because as I explained, I have several female clients, and this is a concern that they have often, is either having pre-diagnosed themselves with bipolar disorder or experiencing symptoms that makes them believe they may need to be assessed for bipolar disorder. So would you then maybe share some general information about bipolar disorder and when a person may need to seek help or seek clinical assessment for their symptoms?
Sure. The main symptom of bipolar is, again, having a manic episode. And many people may not understand what a manic episode is. And basically, having a manic episode basically means that your mood is elevated, so you may feel very euphoric. You may have a tremendous amount of energy. It's also the fact that you require less sleep, and as a result, you don't think as clearly, so you make a lot of irrational decisions, and you also may find yourself spending more money than maybe what you have. You may also be hypersexual, which means you may have multiple partners, and you don't actually recognize the consequences of engaging in those behaviors, which are really many times will cause a lot of problems once the individual does receive medication or does begin to, in some way, become more centered and the disease becomes more manageable. So that's one of the main things, and that's a key piece, because most people think that bipolar is a disease where you rotate a cycle from depression to mania. And that does happen in many cases of bipolar disorder. But the defining feature is having a manic episode. And so that's one of the ways that people can begin to judge whether the behavior rises to that level of a manic episode.
Okay, so what would you suggest then? I'm so sure some people, because people have come to me with this diagnosis and they've often tried to self-medicate themselves using a substance, alcohol, or drugs. What are the consequences then of trying to, I guess, manage your symptoms if they're having manic symptoms with the substance? What would be some of the consequences or side effects from having that combination?
Okay. Many times in a manic episode is also accompanied by psychosis, and psychosis is difficulty managing reality. So a lot of times psychotic behavior will include hallucinations, it may include delusions, but again, it's because you have difficulty really being able to what we call test reality. Unfortunately, using substances sort of sets the stage and makes an individual much more vulnerable to having or experiencing psychosis. So that's one of the dangers when you try and self-medicate, particularly if you are experiencing bipolar. You in many ways increase your risk of having a psychotic episode.
Okay.
And again, because of that, that means that you are much more at risk for not really being able to manage your behaviors.
Sure.
And in many ways that could also lead to a hospitalization. So, and also what we find is that the substances increase sort of the cycling itself.
Okay.
So your cycles become much more rapid. So if you do cycle, let's say from even normal mood into mania, or if you do cycle from depression into mania, it will increase the cycles and make them much more rapid.
I
So
see.
medication, self-medication is really very harmful to
Okay.
bipolar disorder.
Okay, so for the client that has previously been diagnosed with bipolar disorder and is already prescribed medication to manage the symptoms, what would then be, I guess there's some that may not even seek the behavioral therapy in addition to that. A good psychiatrist often would suggest that you seek counseling along with your medication treatment, but I know that not only with bipolar but several other types of mental health conditions that a person that's receiving medication treatment may not pursue having the counseling or psychotherapy in addition to that. So what would you suggest? First of all, why is that important to have both?
No. What we find is if you don't take the medication, the disorder actually gets worse. So that euphoria that many people experience is many times considered a very pleasurable position, particularly if you're coming out of depression. What people don't realize is if you don't treat that bipolar, that euphoria will turn more into irritability, it can also turn into violence. You also, again, will have much more difficulty being able to interact with other people. It sets you up again for being psychotic in many ways. So without getting the appropriate types of medication, again, it's really setting the disease up to progress from maybe mild or moderate to very severe.
So they start to cycle into the decline of becoming, having maybe the hypermania, or maybe even, like you said, they may end up having this hallucinations or being hospitalized.
Yes.
Because they're not adhering to both medication and self-management or behavior management. So is there a cure, or is there I guess a place where a person, when they're doing both medication and counseling or behavior therapy, can they then get to a point, do you know, if they can actually be relieved of the condition altogether, or cured, or appear to be cured?
What we find is with bipolar disorder, there is no cure, unfortunately, but it can be well managed. So that's one of the reasons to become stable. One of the treatments is a mood stabilizer. Okay, if you are having depressive episodes, you will also get an antidepressant. And again, if there's psychosis, you'll also get antipsychotic medications. All of that to sort of balance your mood. You want to stabilize the mood, which is the whole point of it. If you do continue on the medicine, you can maintain that stable mood. All right. So, and that will allow the person to be able to function in society and to be able to work and take care of their daily activities. But there's no cure for the disease. It is considered a chronic disease, and so if you think of something like let's say, having diabetes, it's not a cure for diabetes, but if you manage it appropriately, you can have a very long and sort of successful and prosperous life. You
So
can do
the
the
key
same
is
with
to
bipolar disorder.
become productive with your life. That would be
Yes.
that would be the goal that a person would need to reach. As you said, is to become functional again, and then ultimately be more productive in your life. Something else that occurred to me when we were distinguishing the difference between mood swings and bipolar disorder. There's often the personality disorder called borderline personality disorder that sometimes mimics the symptoms of bipolar disorder. Would you maybe inform us a little bit about that and how the distinguishing differences would present in a client?
Yes. Borderline personality disorder, first of all, is an instability. Okay, it's an instability in one's concept of self. It's an instability because of that poor concept of self, of having not being able to manage interpersonal relationships.
Okay.
So the person will cycle through multiple relationships, and because they're not secure in self, then they also have difficulty being able to reach out and be mutual in a relationship. You know, that mutuality in a relationship is what's so very important to not only maintain it, but also to build a relationship. And so when you have an unstable sense of self, and then an inability to really have the, let's say, the social skills to be in a relationship, that's a big part of having borderline personality disorder.
Okay.
Because of that instability in self, you may see some of the similar symptoms of bipolar. For example, you may see psychotic behavior, okay? You also may see mood swings, okay? And so in that sense, I think one of the best ways of distinguishing it from bipolar, because one of the things, let's say if a person is in a manic episode, they may actually have what we call grandiosity. And grandiosity means that inflated sense of self, where you feel as if you have special powers, or you may feel as if you are the czar of the world or the president of the United States. You have that incredible inflated sense of self. That's not present in borderline personality disorder.
Okay. That's very important to know. That's a key distinguishing factor with what you just said, because that is also another condition that several of the female clients that feel they have bipolar disorder may swing into more of the personality disorder category. Would that personality disorder then be one of the, I guess, issues or concern that aligns with the whole identity issues that you said you see clients that have identity issues, or would that be more of a developmental thing?
No, it's more, the interesting thing about personality, particularly personality disorders, is most people that have a personality disorder, they don't see it as problematic. It's the people around them that see it as problematic.
That's a very good point, yes.
Okay, all right. As opposed to a person who would have experiencing bipolar, they recognize that I am having problems.
Okay.
Okay, all right.
Okay, sure.
And then in terms of identity and, let's say, gender identity or sexual identity, it's not so much a sense of a lack of self or an unstable self, it's just a sense of kind of who am I, you know, and in the sense of what groups do I identify with, because we all need to belong in some ways, and so that sense of identity gives us a sense of belonging to some group, some community. All right. So a big part of that searching for one's identity is also searching for the groups or the groups that I belong to and fit in best with. And so it's not so much an instability of self as opposed to I'm needing to find, in a sense, who am I?
Okay,
and so that's
just not being secure in the identity that you have.
Exactly.
And finding a place of fit. Yeah. That's very interesting. Well, you've mentioned several different areas that I'm sure our audience are interested in, and I'm definitely interested in the whole identity topic, the personality disorder topic, and so those are some of the things we'll probably discuss at another time. However, I'd like to ask you to inform our audience with a way. I know he has a waiting list, but possibly you can get on the waiting list and he can talk to you more and set up an appointment to see him, because he does specialize in several different areas, as you've heard. So would you inform our audience as to how they can reach you?
Okay, all right. There's usually two ways that's best. I'm on a website called Psychology Today Therapist Directory, all right? And that'll give you a lot more information in terms of how I work, what my specialties are, the insurances that I take, the clients that I see, the populations, okay? If you simply wish to contact me directly, I'll give you a reach area code 314-561-2958. And I can talk with you directly and let you know if I have openings, and then we can set up a time that we can meet.
Okay, sounds great. And we will add information on the end screen
Okay.
so that the audience can have that information available to them. And I really appreciate you coming back and joining us. Hopefully we can get Dr. Scott to come back in the future. He's very busy, but maybe he'll make time for us again to discuss some of those other topics. But until then, this is Carolyn Catchings, and I'm reminding you to never attempt to take your path of mental health wellness alone. Ask a therapist. Thank you.
Thank you.
Okay. Very good. Very good.